for attending my talk instead of enjoying this beautiful weather. My name's Tim Boyer. I'm from Northeastern University, and I'll be talking, like you said, about cartilage-targeting cationic carriers for sustained delivery of interleukin-1 in a rabbit osteoarthritis model. Even after a direct injection, cartilage-acting therapeutics have limited bioavailability in the joint. Small therapeutics are rapidly cleared by the continual synovial fluid turnover, and large therapeutics can't fit in the nanometer pore size of cartilage extracellular matrix, comprised of type 2 collagen and negatively charged aggregate gags, whose density increase along with the depth of cartilage. We believe these reasons contribute, in part, to the fact that many disease-modifying OA drugs fail clinical translation. At our lab, we harness this high negative charge of cartilage for the rapid transport of cationic therapeutics. An uncharged neutral solute with unimpeded transport would have the same concentration in the synovial fluid as the cartilage. But if the solute is made cationic, its concentration is elevated in cartilage by a factor K known as Donnan partitioning, which allows for a higher uptake and rate of transport. We've tested a variety of short-length cationic peptides. Those with 14 arginines, or a net charge of plus 14, had 400 times greater cartilage uptake compared to diffusion alone. When we allow the peptides to absorb into cartilage for 24 hours, those with too high of a positive charge, like you can see with plus 20, stuck to the surface, while plus 14 penetrated the full thickness. It's important that these carriers are designed to have an optimal net cationic charge so that they can take advantage of weak reversible binding with gags in order to reach chondrocytes in the deep zones of cartilage. And for the remainder of the talk, I'll refer to this optimized cationic peptide carrier plus 14 that we discovered and talk about how we plan to test it for the delivery of OA therapeutics. In particular, I want to talk about targeting IL-1, which is a classic inflammatory cytokine that is elevated after joint trauma and binds to its receptor. IL-1 receptor antagonist, IL-1RA, blocks this receptor, preventing IL-1 from binding and subsequent inflammation. However, IL-1RA has a short residence time in the joint after an intra-articular injection and is mostly cleared to the vasculature by 4 hours. So in order to enhance intra-joint retention, we conjugated IL-1 to CPC using site-specific bioconjugation techniques. Using an IL-1 challenge cartilage explant model, we measured the amount of GAG matrix loss from an explant surface. You can clearly see that explants treated with IL-1 every 2 days resulted in significant GAG breakdown and release into the medium. A one-time dose of IL-1RA alleviated cartilage breakdown at day 2, but was ineffective in the long term. However, a single dose of CPC IL-1RA improved cartilage bioavailability and prevented IL-1-induced GAG loss. And these results were corroborated with staining for live cells green and dead cells red after 16 days of treatment. So, inspired by these results, we sought to first evaluate the biodistribution of these cationic peptide carriers in a rabbit ACLT model of post-traumatic osteoarthritis, and secondly, use computational modeling to design cationic fusion IL-1RA protein from a single amino acid sequence that can still bind to its receptor. To mimic a knee injury, 12-month-old female rabbits were given ACL transection in the right knee, while the left knee had sham surgery or opening of the joint with no transection. The rabbits recovered for 1 week and then were injected with 300 micromolar of Sci-Fi labeled CPCs. Animals were euthanized and tissues collected 1 or 7 days after the injection. You can see with the camera images that the bright blue color of CPCs is present in the cartilage of sham-operated rabbits, 1 and 7 days after injection. Using confocal microscopy Z-stacks, we found CPCs penetrate into the full thickness of cartilage tissue. This occurred, but to a lesser degree in the knees which received ACL transection, and we'll come back to this. We further validated this full thickness penetration in rabbit cartilage with light sheet microscopy, and overall we found the concentration of cationic peptides strongly correlates with the anionic GAG density in individual tissues. Looking at the graph here, the average value 7 days after injection, you can see the highest CPC uptake was in cartilage, which has the greatest negatively charged GAG density, then the meniscus and quad tendon, and finally CPCs were marginally detected in tissues lacking GAG. So we further quantify the concentration of CPCs in these individual tissues like cartilage. The femoral condyle of sham rabbits had the highest concentration, 1 and 7 days after injection. ACL transection knees still had a high concentration of CPCs, but it was reduced compared to sham knees at day 7. And we thought of a couple explanations for this. We noticed a marginal decrease in the superficial zone gags 2 weeks post ACL transection, indicated by the safrana nose staining, which may explain less CPC retention. We also measured the amount of CPCs cleared into the blood serum and found a slight elevation in ACLT knees 30 minutes after injection, which may be due to some increased synovium permeability. And moreover, highly elevated proteolytic enzymes may be cleaving our peptide, and tissue volume increases due to inflammation might dilute total CPC available for cartilage targeting. CPCs at high doses do not increase inflammation. The addition of CPCs did not elevate macrophage infiltration into the synovium. We did not see elevated knee swelling compared to saline injections. And lastly, there was no additional inflammatory cytokine expression within the synovium. Okay, so coming back to the therapeutic. Now that we know CPCs effectively target cartilage and are safe, we wanted to fuse the amino acid sequence of CPC with the amino acid sequence of IL-1RA in such a way that IL-1RA still folds correctly and binds to its receptor. So we used molecular modeling to design several variants with CPC on the N-terminus or C-terminus, with or without 3 different types of linkers. We docked each one to the IL-1 receptor and predicted their binding free energy to this receptor using molecular dynamic simulations. And we found that CPC on the C-terminal of IL-1RA with a semi-rigid hybrid linker bound the best. So we produced it in HEC293 cells and demonstrated it prevented IL-1-induced IL-6 secretion in chondrocytes, the same as pharmaceutical-grade IL-1RA. These results are just in vitro. But here you can see that we've successfully designed a cationic IL-1RA that can effectively bind to its receptor, but now with superior cartilage-targeting properties. In conclusion, small OA therapeutics have limited intra-joint bioavailability even after a knee injection. CPCs enhance cartilage uptake by 400 times and can be used to deliver drugs. They're safe to use, have full thickness cartilage penetration, and high uptake in rabbit cartilage tissues. And using molecular modeling, we designed a cationic fusion IL-1RA that retains receptor binding. Our ongoing work is to see if early and sustained administration of cationic fusion IL-1RA in a rabbit model can prevent osteoarthritis onset in vivo. I'd like to acknowledge my advisor, Dr. Ambika Bajpai, the members of my lab, our collaborators, Dr. Brian Porter and Pete Childress at UMS, and our funding from NIH. And we got another talk from the lab in 103 after this session. Thank you very much.
This paper is now open for questions.
Hi, Carly DeJulius from University of Michigan. That was a really excellent talk. I was curious how the charge of your nanocarrier system compares to your recombinant protein, if that was matched, and if you have any thoughts on if the recombinant protein is smaller and how that affects penetration as well.
Yeah, so the cationic peptide carrier is about, is only like I said, 20 amino acids long. And so it's probably about a third of the width of like interleukin-1 receptor antagonist, which is a negatively charged protein to your first question. So by making it positively charged, we're optimizing it for transport. And so, you know, the goal is that we can use less amount of IL-1RA and show superior, you know, transport in cartilage to make it an effective therapeutic. Thank you for your question.
Thanks so much for that talk. Danielle Minoy from the University of Oregon. I was curious about the hybrid linker. I don't think I caught what that was. And then are you doing synovial injections? How are you delivering your peptide IL-1 agonist?
Yeah, so to answer the second question first, This is an injection into the intra-articular space with a anterior lateral approach. So injections right into the synovial fluid. And the first question is about a hybrid linker. Yeah, I had to go fast through that. So we tested different shapes of linkers in terms of their secondary structure. So we had a flexible linkers made of primarily glycine amino acids, which don't form a secondary helix. We tested amino acids that should form a alpha helix, and then we tested ones that a combination of it has a little bit of a flexible region and then a helical region to it. So we wanted to move the CPC sequence a little bit away from the IL-1RA protein so that we can still retain that receptor binding, which we should. Yeah. Thank you.
Let's thank your speaker again.